So first I'm going to present some unknown cases, and I'm not going to give the answers, but the answers will come up during the presentation. So just make note of some of the findings initially. 3-month-old with stridor, plain radiograph, frontal radiograph of the neck, and a CT scan near the thoracic inlet. Here's a teenager with a chronic cough. There's several classic findings here. We'll see this case later. Makes a few observations quickly, and we'll get back to it. Here's a CT scan from the same patient, and there's 2 observations you can make on that. Close-up image, it may help you figure out the diagnosis. Infant boy with tachypnea, some asymmetry in the lungs. We'll see some more imaging later. Here's the CT with the asymmetry very apparent, and another infant also with tachypnea, also with asymmetric aeration and a different appearance on CT. And finally, a child with fever and respiratory distress. Notice some of the observations in this, and we'll discuss it as it comes up into the lecture. So when we talk about airways in pediatric imaging, we're going to talk a lot about what's traditional. We're going to show mostly plain radiography, but as time has gone on, we use more advanced imaging, CT and MR, to help supplement some of the initial imaging that we do of the airway. The SPR, the Society for Pediatric Radiology, has a curriculum for residents that is very helpful for your board preparation. And if you go to pedrad.org, you can find the curriculum, and I think that'll have a list of pretty much what you need to know for the board preparation. Today we're going to discuss some normal variants and then some congenital, inflammatory, neoplastic, and traumatic injuries to the airway and chest. We won't have time to talk about problems in the neonate, but I think that many residents are more familiar with neonatal chest than other aspects of airway imaging. So when we look at a lateral neck, first we have to understand the anatomy, and this schematic diagram shows some of the things you need to know. The base of the tongue often has some lumpy, bumpy appearance, which is lymphoid tissue, the vallecula, the epiglottis, and we can follow the same thing on a plain radiograph. There's the vallecula, epiglottis, aryepiglottic folds, and those are important landmarks to recognize, as is the retropharyngeal soft tissues. On the frontal view, here in a schematic diagram, radiograph, and here's a volume rendered rendition, you can see the area of the true cords is where the larynx is, the vocal cords, and you can see a little bit of the piriform sinuses, and then the shape of the proximal trachea is fairly characteristic and normal. Now, what we see in infants not uncommonly is what looks like retropharyngeal soft tissue swelling, but in this case, it's just in expiratory phase film. The same child, a few hours later, when it was called back for a repeat, shows that the retropharyngeal soft tissues are normal. So don't be fooled by a single radiograph which may be obtained during expiration. Similarly, we expect to see the nice shoulders of the trachea, and occasionally, I don't know how well this projects, but the trachea often buckles to the right. That shouldn't be misunderstood as a mass in the left upper mediastinum, but rather the normal buckling that you see in a trachea in a young infant with a relatively compliant trachea during expiration. Another thing that we see very frequently during esophagograms and other fluoroscopy is a narrowing of the trachea on the lateral view. Again, I'm not sure how well this projects, but you can see that on this middle image, the trachea looks very narrow on the lateral view, and that's generally during expiration. And in the same examination, a few seconds later during inspiration, the caliber of the trachea will be normal. That's just tracheomalacia. It rarely leads to any problem clinically. Most of the time it's just a normal variant, and they outgrow it as the trachea becomes more firm. On the other hand, there's an impression that we see occasionally on the anterior trachea that occasionally, and actually rarely, is a problem. And here you can see on an MRI, there's a trachea which is narrowed and a vessel crossing right in front of it. And this is the so-called innominate artery impression. Most of the time it's not symptomatic, it's just a little indentation. Rarely there's compression that would need to be dealt with clinically. Now, in children, we frequently see a large thymus, but on occasion we see a density behind the thymus that might be tricky. In this case, who happened to have a CT, you can see that there's a large thymus, and there's actually a little bit of a posterior projection of the thymus, which is a bit unusual, but the shape and the size of the thymus is quite variable, and it's not uncommon for us at a children's hospital to be referred patients for mediastinal mass that turns out just to be a thymus. So these are some of the normal variants, and in the interest of time, I'm not going to read some of the lists that are in your syllabus, but rather move on to show you more of the cases that you're probably more interested in seeing anyhow. Again, with airway obstruction, I'm not going to read everything on every list, but we're going to go from the nose down to the bronchiole and show a variety of conditions that we see in a pediatric radiology practice. Starting from the nose, we'll show a few examples. Here's two examples of a condition which you probably already thought of looking at the picture. This is a bony example, and this is a membranous example of choanal atresia. You can notice that there's a patent nasal passage on one side here, so this is a unilateral, and this is a bilateral condition. Newborns are obligate nasal breathers, so if they try to eat and breathe at the same time, they get in trouble, and they can't pass an NG tube. Generally now we use CT for diagnosis. It's very quick. You can use relatively low, or you can use a very low dose. Bilateral is more common than unilateral, and bony choanal atresia is more common than membranous. And it's important to distinguish from this next condition that which we'll see here. This is the child with a membranous choanal atresia. Notice this child also has nasal obstruction, but has patent choanae, but the anterior inlet, or the piriform aperture, another term for it, is very stenotic. So it's a very interesting condition, less common, but it's important to recognize because they may be able to pass a 5 French feeding tube, or they may be unable to pass a tube, and they request a study looking for choanal atresia, and you might find this instead. The curiosity about this particular condition is they often have a single central incisor, and because it's a newborn, it's not erupted, so it's under the gums. So in the CT scan, you'll see a funny single central incisor. Here you can see curved coronal reformation. They can also be associated with midline brain defects, so it's important to do some neuroimaging as well. So moving into farther down the airways, you can see there's a large mass which is moving or eroding some of the bone on the CT scan, and here on the MR you can see a large enhancing mass originating in the nose or nasopharynx, causing nasal obstruction. This turned out to be a juvenile angiofibroma, very vascular, generally would require some embolization prior to resection. This was actually a child of one of our staff pediatricians who presented with epistaxis and nasal obstruction. Another child with a MRI, you can see obstruction in the nose, a soft tissue mass. This turned out to be a rhabdomyosarcoma. So there's a wide range of lesions that can cause nasal obstruction. This is much more common. These are two different cases of marked enlargement of the adenoids and tonsils. Here you can see that not only is there enlargement of the adenoids and the area of the tonsils, but also retropharyngeal soft tissue swelling. So this is pretty common in teenagers and older children to have large tonsils and adenoids. And in particular, mononucleosis can be quite important as a cause of airway obstruction. And if you happen to do a CT, it often looks very funny. The enhancement pattern is funny. So always consider mono when you see the tonsils, adenoids, and retropharyngeal soft tissues. And moving along, you can see, as we're coming down the nasopharynx, you can see that the soft tissue in the retropharyngeal or prevertebral space is too thick. And if you were sure that this was taken properly and in inspiration with as much extension as possible, you would suspect that there was an underlying lesion, in this case, retropharyngeal abscess. Most of the time now we do a CT scan to help the surgeons decide whether to drain it and where to drain the lesion. And here you can see the retropharyngeal abscess with rim enhancement seen on both the axial, coronal, and sagittal reformations. Another case of retropharyngeal soft tissue swelling, this one is different in that you see air in the soft tissues. And it's very, very uncommon to see air in a retropharyngeal abscess unless there's a foreign body and a puncture wound from a foreign body. So the organisms that generally cause retropharyngeal abscesses do not create air unless there's been a puncture wound. And here's another one where you can see air in the retropharyngeal soft tissues. And on the CT scan, there's a little fishbone that was caught in this abscess with a little air and a fishbone. Moving down the nasopharynx, we talked a little bit about the adenoids and retropharyngeal abscess, some of the other tumors that can cause nasopharyngeal obstruction. Now here's an Aunt Minnie that everyone needs to know, although I would assume that many in this room have never seen a real case of this particular condition. Do you know what this is? It's epiglottitis. How many of you have actually seen a live case of epiglottitis? So it's becoming much, much less common. It's less common because of Haemophilus influenza immunization. And I'm going to show you the last two cases we had. It's a life-threatening emergency, and every institution needs to have some policy to deal with it if and when it comes. We used to see it much more commonly. And here's our last two cases of epiglottitis, and they were both a little bit unusual. One was an HIV-positive child who had immunization, but it didn't work. And the other one is a child who had a bone marrow transplant, and this has been reported, and they're not exactly sure the mechanism, but some children with bone marrow transplant will develop a form of epiglottitis. Again, the characteristic is thickening of the epiglottis, a thumb type of sign, and marked thickening of the area epiglottic folds. So remember the landmarks that we saw on the original normal. You have to recognize and see how different that is, because it's a life-threatening condition. There aren't too many life-threatening conditions, but this is one of them that you have to recognize even though it's rare. Moving down the airways and moving right along, it looks better on the screen than it looks on my screen. You can see that there's narrowing of the subglottic trachea, and if you would imagine a pencil point or a steeple, this would be a pretty characteristic steeple sign condition we all know as croup or laryngotracheobronchitis. Here's another frontal view, which is more characteristic. It's easier to make the diagnosis on the frontal view, and on the lateral view it's often misleading because the narrowing is more side to side than it is front to back, but in this case there is some narrowing in the subglottic trachea, and occasionally during inspiration you'll see ballooning of the hypopharynx. It's a fairly common disease. We don't image all children with croup, and if they want to make a positive diagnosis of croup, the frontal view is better than the lateral view. But often we get lateral views just as a remnant of looking for epiglottitis. Generally younger children, it must be tapered and symmetric, and there's an occasional condition called bacterial tracheitis, which is very uncommon in California, seems to be seen more in the Midwest where I did my fellowship, but we don't see it very often. But it's very important to make sure that you distinguish it from other causes of stridor, because if it's a recurrent stridor or something is unusual, you might have to investigate further to make sure it's something other than croup. And here in a schematic diagram, you can see the normal shoulder of the subglottic trachea. Here you can see the typical tapered symmetric narrowing of the subglottic space in croup. And if you see anything that is not completely symmetric and tapered, you have to be concerned that it could be something else, such as a subglottic hemangioma. And if you recall, our first unknown, here it is. This was the asymmetric narrowing of the subglottic trachea. Remember, unknown 1. And here on the CT scan, you can see the thyroid gland, the carotid artery, the jugular vein, and here you can see a enhancement of this subglottic hemangioma and the tracheal narrowing, which is impressing on the right side. This is color rendition. Sometimes we do a CT because it's quick and we don't want to sedate the child because they're having airway problems. This child required intubation. You can see part of the tube, and here you can see an MRI without radiation would also show very well the hemangioma, which is in the glottic region, subglottic region. Here you can see how the lesion would cause some airway symptoms. They tend to be relatively asymptomatic at birth, just like the hemangiomas you see on the skin, and then they grow over the first few months. So they may develop stridor where they did not have it at birth. Sometimes there are mixed lesions. Here you can see some areas with enhancement, some areas with cysts, some with fluid levels, and this is a mixed hemangioma and lymphangioma, so they can coexist. Now we try to use MRI in the face and neck if possible to avoid radiation, but occasionally we use CT if we can just throw them in there without any sedation and establish the diagnosis quickly. As I said, the stridor may increase because it's not very big at birth, and then it grows over the first few weeks or months. This is a case of membranous croup, which you can see a little membrane, which is basically mucus and cells. Usually in older children, they have a higher fever and associated with bacteria, not just a viral infection. Notice that this is not the normal appearance of a subglottic trachea. There's not a normal shoulder. There's some indentation here. It doesn't look like croup. So in that case, you have to think of what else could it be. This is a post-traumatic subglottic stenosis in a child who had previously been intubated and has some narrowing in the subglottic trachea due to prior trauma from intubation, and another one as well. There are a variety of conditions in the trachea. We'll see some of them during the course of the next few minutes as we go through here. And here's a child who presents with airway symptoms and stridor. And what do you see? Metallic foreign body. You can also see that if it's in there long enough, it'll create some inflammation and narrowing of the adjacent trachea. Anybody know what this is? I think it's a quarter or nickel, dime. It's actually the ship from Monopoly. It shows the importance of two views in radiography. It's a different case. We used to put Foley balloons and blow up the balloon and pull the coins out, but it was relatively contraindicated in the children who had a thick space between the trachea and the esophagus. We don't do this anymore, maybe for medical legal reasons or the surgeons want the business, but it was a brutal procedure. We did it a lot, and so I'm glad we're not doing it anymore. Moving down into the trachea, into the chest, here you can see there's some asymmetric narrowing of the intrathoracic trachea and a soft tissue mass in the mediastinum. Here you can see the soft tissue mass extends to below the carina, and here on an older exam, a reformation shows there was complete narrowing or complete obstruction of the right mainstem bronchus from this moderately extensive lymphoma or Hodgkin disease. Here's a child with asymmetric aeration. We're going to see several of these. Some of the unknowns were asymmetric aeration. Notice that these ribs are splayed. There's some bulging of the pleura. And one important cause of this type of asymmetry in children is a foreign body. In this case, a foreign body in the left mainstem bronchus where there is obstruction of the mainstem bronchus and air trapping during expiration. In children who can't cooperate with inspiration and expiration, we'll frequently do decubitus view, hopefully in expiration. And here you can see on the right side, the right lung deflates, and when the child is placed on the left side, the left lung does not deflate, so that it implies that there's obstruction. You can also, if we go back and forth, you can kind of see the same thing, that inspiration and expiration will show a paradoxical motion of the diaphragm. The reason I show this is a very old case. This demonstrates a foreign body in the right mainstem bronchus, but it's an old case, old scanner, slower scanner, and a lot of motion artifact. And I just want to discourage you from using CT to evaluate foreign bodies. We don't do it. Generally, if there's a suspicion of foreign body, you have to use bronchoscopy and look for it because we can't diagnose it. We could probably diagnose it reasonably accurately, but it's not going to avoid the bronchoscopy. And there's a lot of radiation in CT. So foreign bodies are important. They can occur anywhere from the nose down to the bronchi. To make the diagnosis, you must first think of the diagnosis, and if you don't live in the pediatric medical world, sometimes it's hard to remember the kind of things, the trouble that kids get into. Here's a case from our ICU a few years ago. It was right middle lobe pneumonia and some left lower lobe pneumonia, and for days we just said, oh, we also had a positive RSV. So we never got a lateral view until they said, oh, by the way, there's stridor. So then we got a lateral view and subsequently an esophagram, and we can see that there's narrowing of the trachea, which may be hard for you to see, but a posterior impression on the esophagus. In this child who initially was just thought to have RSV, the stridor was due to a vascular ring. So for vascular rings, we either do MR or CT, and in this case it was a few years ago we did a CT, and you get a volume of tissue, and you look and segment out what we need to, and you can see that there's a double aortic arch and a narrowed trachea associated with this vascular ring. Here you can see a larger right arch, a smaller left arch, and if you look from behind, you can see it's an incomplete arch with a cumeral diverticulum here posteriorly, and here looking from below, it shows you what a vascular ring, the features of it, the right arch, the left arch, the cumeral diverticulum, and then there's a ligamentum that would join this diverticulum to the other arch, surrounding the trachea just where it's narrowed. Here's another child who had a deviated trachea. Notice instead of buckling to the right, it's buckling to the left, and another vascular ring. So vascular rings are generally double arches or right arches with an anomalous left subclavian. They cause tracheal narrowing with a posterior impression seen on an esophagram. Now here's something a little bit different. Notice here's the trachea, here's the esophagus, and instead of a posterior impression, there's something in between the trachea and the esophagus. Here on a schematic diagram, you can see what it is. So this is known as a pulmonary sling or an anomalous left pulmonary artery. We'll see here's an old MR. Sometimes they're associated with kind of a low carina and narrowing of the trachea because of tracheal rings. It's about half the cases of them, they have tracheal stenosis as well. And here you can see the pulmonary artery and an old MRI coming behind the trachea and going toward the left. Here's a newborn that we had. Instead of an esophagram, there was a NG tube. You can see the trachea and something in between. This is another case of a pulmonary sling. And here you can see on the CT scan the main pulmonary artery, the right pulmonary artery, and then the left coming off, going from the right behind the trachea to the left side. So here you can see it coming behind the airway, typical pulmonary sling. There are cases also of congenital tracheal stenosis, and that's what this turned out to be. Here you can see the volume rendition of the airway. The upper trachea looks fine, but there's a severe narrowing of the distal trachea. There's a anomalous bronchus here, and this is a congenital tracheal stenosis, very difficult to treat. But those are generally complete cartilaginous rings that would make it stenotic at that level. Now, sometimes we're called on to do cardiac studies, and here you can see a child with a truncus, a repaired truncus. We were going to look for the vessels and see where the pulmonary arteries are and how big they are and so on and so forth. And in the course of doing this exam, I decided to look at the airways as well. And you'll see that there was a right arch and a accessory bronchus here coming off the trachea, also known as a tracheal bronchus or bronchus suis, a pig bronchus. And with the current technology, we can easily reconstruct the data, make it look like a virtual endoscopy. And here you can see the carina, and here's the tracheal bronchus coming off the right side of the trachea. Now, remember that we should see the epiglottis and aryepiglottic folds. The laryngeal ventricle should be dark, and there's something extra here. So you have to know your normal anatomy to know that there's something extra. No additional imaging was performed. We just suggested endoscopy, and here you can see a papilloma at the level of the cords. So laryngeal papillomatosis is something to remember as a cause of stridor. It's an acquired infection from a virus. Occasionally, it can go down into the larger airways and can go into the lungs and cavitate. In the interest of time, I'm going to go a little bit faster. Here's a child with opacity in the left lower lobe. It's kind of hard to see the left mainstem bronchus, but here in a close-up, you can see that there's some narrowing of the left mainstem bronchus, some opacity in the left lower lobe. A different case with a difficulty seeing the right mainstem bronchus, some hyperinflation on one side. And this brings us back to our case number 2. There's an Aunt Minnie finding of something. What is the haziness here and the anterior density on the lateral film is classic for what? The left upper lobe collapse, right? And if you look a little bit closer, as we get into if you look closer, you can see that there's a granuloma here. And if you recall the CT scan, you can see that there's a calcified pleural granuloma or pleural base granuloma and a tree and bud appearance of the small airway disease peripherally. So this was a case of tuberculosis, something unfortunately we still see fairly frequently. We have a pretty large tuberculosis clinic. We also do use advanced imaging, mostly CT, for evaluation of this condition, which has some variety. This is a bronchiectasis. This child had CF. Another one of these children had ciliary dyskinesia, but you can have from bronchopulmonary aspergillosis, tuberculosis. Other causes can lead to bronchiectasis, which can have a variety of appearances, either air-filled or mucus-filled bronchi. Child with asymmetry in the lungs. Notice that there's a curvilinear structure here, which I think will help you figure out what this is. The scimitar, it's not really a syndrome, it's a constellation of findings, and some of which are a hypoplasia of the lung. Here you can see the right lung is smaller than the left. You can see the pulmonary artery on the right, pulmonary vein on the right are smaller than the opposite side. The bronchi may be asymmetric as well, and it's better to think of it as a complex of findings that may be associated, sometimes known as congenital pulmonary venolobar syndrome or hypogenetic lung. There can be a variety of features that are associated with it, and that's in your handout. In the interest of time, we'll just keep moving on. Here's the next unknown. Notice that there was some asymmetry in the lung, some lucency in the left upper lobe, and notice that there are branching pulmonary structures, vessels in this. This is congenital lobar emphysema. There's another case of congenital lobar emphysema. It's important to recognize that at 2 hours of age or immediately after birth, whatever abnormality is there is going to be fluid-filled, and over time it may become aerated and then hyperinflated depending on the timing. So it depends on when you get the chest x-ray. If they may not present with any respiratory distress early on, and you may not see the phase where it's fluid-filled. But obviously in utero it's fluid-filled. Sometimes lobar emphysema is associated or similar to bronchial atresia. It has a very similar appearance, but you may see a bronchial impaction on CT scan. Another child has a mass in the left upper lobe. This is on CT scan, you can see it's fluid-filled. This is a bronchogenic cyst. They may be fluid-filled, or later they might become infected or air-filled or have air fluid levels, a variety of appearances. There's some arrows here to help you focus on the abnormality in the left lower hemithorax. This is an extralobar sequestration. Here you can see it along the diaphragm, and if you look carefully, there's an extra vessel that comes off the aorta near the celiac axis. And with a little bit of fun at the workstation, you can make the systemic arterial supply to the sequestration look very similar to the surgical specimen. Here's a case where an extra vessel comes from the descending aorta but supplies part of the lung. This is an intralobar sequestration, sometimes associated with little focal air trapping. And again, sequestration is important to understand. In the interest of time, I won't read all this, it's in your handout, but to recognize the differences between intralobar and extralobar sequestration and their associations. Next, unknown from the beginning. Notice this is asymmetry. There's, if you look very carefully, you might see another cyst here. You don't see any pulmonary vessels or other ordinary pulmonary markings. There's some shift of the mediastinum and some herniation to the other side. And on CT scan, instead of seeing the normal branching that you would see in a lobar emphysema, you see really no particular architecture. Here you can see a cyst, here you see a septation, and there's no pulmonary structures in here. So this is a CCAM. This one happened to have one predominant cyst, but there can be a variety of appearances. They may have a variety of size cysts, but they don't have the normal structures like a lobar emphysema. Bronchopulmonary foregut malformations is sometimes a way of characterizing a lot of these conditions that we just saw, and again, this is in the handout. Moving right along, here's an interesting case of a mosaic pattern. When you see this in adults, you have a differential diagnosis as we do in children, but ours is more limited since we don't tend to have vascular disease. So when you have a mosaic pattern like this, we're more likely to have small airway disease. And here you can see with inspiration and the same patient with expiration, you can see this mosaic pattern. This is bronchiolitis obliterans, different than BOOP, which is with organizing pneumonia. This is an interesting condition. I think this is in your handout. It tends to be post-viral, but usually not RSV, and it's in children who have pulmonary symptoms that are hard to explain. This is a child we had. I did a minimum intensity projection just for fun to dramatize the findings, but I also noticed that the child had a tracheal bronchus as a supplemental finding. And here's the final unknown. We didn't talk a lot about lung disease itself. We concentrated mostly on the airways. But here you can see the unknown that we had. There's a large pleural effusion. There's some lung here which is enhancing. There's some lung here which is not enhancing. And then on follow-up, you can see that there's some cavitation in parts of the lung. And this is just one of the terms we use is necrotizing pneumonia. They're very common. In the winter, we might see 10 or 20 or 30 of these, depending on the season. And the children tend to do well. Often they need some drainage of the pleural effusion. In summary, I think we looked at the airways from the nose all the way down to the bronchiole, covered what we could in the short time we had, and I wish you all a lot of luck on the boards.